Good to see you all, and thanks for taking time out of your evening, certainly to meet with me. I appreciate it, and it's my pleasure. I know that everyone is getting crushed and seeing more patients than ever before coming back after post COVID pandemic. So thank you again for taking some time out to hear about the EMS transfer of care time process. So I started out just with a few brief slides talking about just a general summary, general overview. Maryland EMS responds to over 1 million calls every year, transports about 500,000 patients in a year. And in Region 3, which is the Baltimore metro area, this equates to really 1 transport every 2 minutes. So quite a busy system, just like the busy hospitals, busy EDs that we work in. Just a word about EMS transfer of care time. If you read the national literature, people will call this different things. They may call this APOT or ambulance patient offload time, or just offload time. One reason we decided to use transfer of care time is it sounds more like what we're doing as opposed to unloading packages, and like UPS would, we're transferring care, from one healthcare clinician to the next. So in general, when I talk to you about transfer of care time, people may do this slightly differently. What I'm conveying to you is the arrival time at the destination until the EMS clinician marks that they handed over care to usually a nurse. And there's a signature line and also sort of a manual entry field that they're able to put a time into. So I think really important to understand is that the absolute values with these times are probably less important as the trends. Because it does rely on some automated feeds from their 911 center and some manual data input. The arrival at destination time, 1900 hours or 1901 hours, is usually created by them radioing to their 911 center that they've arrived at a given hospital. And sometimes they'll radio as they're backing in, sometimes it says they're pulling into the driveway. Sometimes but it's usually before the vehicle is shut off. So there could be some variability in that. The transfer of care time similarly is when they're actually handing over care to either the patient or physician in the room, not when they're in the hallway with registration. So I know, again, several different definitions, several dashboards use slightly different definitions, but I just thought I'd cover that from the start here. And then as a broad overview, most of the hospitals in the state are receiving a weekly EMS transfer of care report. Used to be on a Friday, we've moved it to the Monday. Now with the help of the data shop at MIMS, which now gives you an individualized look at your hospital's data, as well as the regional and state median time and 90th percentile time, and the proportion of patients that are more than 60 minutes, 60 minutes on the stretcher pending transfer. So if you're not receiving those currently, please let me know. I'd be happy to give them to you for your hospital. In general, we didn't want to fill up a bunch of inboxes of people that really didn't want them. But I'll tell you, it's about 36 or 37 hospitals now that are currently receiving those. So it's most of the hospitals, and really the ones that are not tend to be in the farther reaches of the state where this is less of an issue. But in general, the volume and times have been increasing, particularly in Central Maryland and within the National Capital Region, what we'll refer to as Region 3 for Central Maryland and Region 5 for the National Capital Region. And this is just showing you, I give this talk in different forums. Not everybody's necessarily familiar with the lingo. Generally tends to be, our major issues tend to be in Regions 3 and 5. Regions 1, 2, and 4, while they have issues from time to time, are generally, they're not immune from having problems, but they generally don't have the lion's share of these issues. So this is looking back late 22 into early 23. Just to orient you a little bit, this is transfer of care time in Region 3. So this is Central Maryland, Baltimore Metro, looking at the mean, median, and 90th percentile. And what I mean by 90th percentile is the time it takes to unload or transfer care for 90% of the patients. And where that comes from, many of you are familiar, is the high reliability organization, that if you have a process and you're good at doing that and you're a highly reliable organization, generally speaking, you should be able to do the process 90% of the time pretty consistently well. accounting for the fact that you're going to have about 10% outliers. There's going to be exigent circumstances. We work in an ED. We don't work in the airline industry as we are often compared to. There are factors that are outside of our control. So you can see kind of what this has been doing over time. I will tell you that while it's tempting and sort of appetizing to look at median and mean, that the 90th percentile really does tend to reflect the stress in the system, where we really start to hear about issues is when the 90th percentile is creeping up. And over this period of time, again, this is accounting for arrival to transfer of care. I generally would subtract 5 to 10 minutes from whatever the reported 90th percentile time is, just accounting for patients having to come in from the ambulance, talk to registration, et cetera. And actually the folks at LifeBridge at Sinai had done some analysis for me for several weeks. And the times that I'm reporting out of the EMS system, the EMS system, were consistently 5 to 10 minutes longer than those in Sinai's EHR. And it makes sense over time, right? I mean, they're marking that they've arrived a little bit sooner than when Sinai or any given hospital would register the patient. So you can just picture a line graph with 2 lines and they're evenly spaced. So there's going to be a little bit different if you run this in Epic or your EHR versus what EMEDS reports, and that's okay. But what I think we ought to be concerned with is what the trending is doing in general, because those things do tend to hold true. This is a comparison to Region 5, so National Capital Region, where we see a little bit more of a discrepancy between the median and 90th percentile. Tends to be a little bit more volatile than Region 3. There's a sort of a wider gap, if I flip back for a second, between the median and the 90th percentile. There's a smaller gap in Region 3, a little bit wider gap in Region 5, but still pretty similar in terms of the overall numbers. Just to put this in perspective, the total number of EMS hours of wait in Region 3 by month. So I know maybe the numbers are kind of small. It's around 8,000 or so. And that was a partial month in January. So about 8,000 hours. This equates to roughly needing to staff 1 additional medic unit in a county like Montgomery County for that given county, and it equates to staffing about 4 medic units in Baltimore City worth of time. This is just showing you in Region 5, same kind of graph here. So I know a lot of times we can get lost in the details. We can talk about medians and means and so forth, but these are sort of the individual patient experiences in Region 3 and Region 5. The numbers of patients that experienced a wait time that was more than 3 hours, 2 to 3 hours, or 1 to 2 hours. And remember from our prior discussion, Region 5, while a busy area, is just a little bit less busy than Region 3 at this point, at least in terms of EMS volume. So along came this concept of a word that I really don't care for, to be honest, forced offload. I think there are other monikers we might attach to this, but forced offload was what was chosen. It actually took root in Queen Anne's County, the Upper Eastern Shore, when they started to have some difficulty. They hired a legal firm, Page, Wolfberg, and Worth, to sort of craft this document to them, and for them, I should say, and a lot of this rests on EMTALA. Essentially what this says, and this is the Reader's Digest version, is that at 20 minutes, EMS may be requested to remain with the patient, request by hospital staff. At 40 minutes, hospital supervisors can request EMS supervisors to grant another extension of 20 minutes. And then at 60 minutes, we really ought to be looking actively for either an appropriate bed or a location for the patient. And I'll tell you from Anne Arundel County, where this really, even though it started in the Upper Eastern Shore, where it was really used first was Anne Arundel County. Their experience with these quote unquote forced offload patients is that they are not running around your ED looking for open beds and throwing people into them. I think that's what a lot of us think of, and frankly, that's sort of what the name implies. But the experience has really been at 60 minutes. There are still patients on stretchers. There are patients for whom, at 60 minutes, they've sort of declared that they're stable and they may not go to a monitored bed or a stretcher. But regardless of where the patient ultimately lands, the patients that are in the forced offload cohort Their average time is around 84 minutes. So what this is in effect doing is it's not necessarily reducing the overall mean and median, but it's taking some of the very, very extended wait times that I showed you a couple of times back, one slide back actually. So these 98 in region 3 and 96 in region 5, and it's sort of chipping away at those extended, very extended wait times, which again, I think we would all argue is probably in the patient's best interest as well as everyone's best interest, the EMS system's best interest. And I showed you here a de-identified, this is actually out of one of the weekly reports that the hospitals receive. If you're not familiar, if you've not seen this before, we're showing year to date here, median on the bottom and 90th percentile at the top. And this is a quote unquote hospital in the forced offload zone. So you can see that despite forced offload and these policies, that overall the median and 90th percentiles remain either close to or above even where the regional and state averages are. And I'll show you those on the next few slides. So it's really not the apocalypse like I think some were wont to think. This one's a little bit busier, but again, this is what's received by the hospital every week. These are median times year to date in 2023. With region 3, region 3 is the green line here, region 5, National Capital Region, is the blue line, and the pink or magenta line, the one that has a bunch of 19s and 18s, is the state average, the state average median, if that makes sense. So this is what we're actually seeing year to date so far, around 22 minutes for the median time in region 3 and around 20 minutes in region 5. If I show you 90th percentile, it looks pretty similar, right? You see the same lines clustered at the top, same lines clustered at the bottom. The bottom lines I was sort of remiss a little bit in not mentioning on the prior slide are regions 1, 2, and 4, the Eastern Shore and Western Maryland. So we see that those times sort of hovering around 50 or 51 minutes in the metro areas. But if you look all the way to the left of the graph, we have been making some progress jointly as hospitals in reducing that 90th percentile time, as ED leadership has put this on their radar as a metric to improve upon. And really, I think we can continue to make progress. And I think I'll talk a little bit later about the collaborative of hospital emergency services and some of the work that they're doing. But just to give you a frame of reference, this is sort of where we are and where we have been in the last couple of weeks, year to date. I think really this is pretty impressive. If you see these are the patients that spent more than 60 minutes waiting for a bed, or waiting for EMS transfer of care. The green line again is region 3. On this one, the purple or magenta line there is region 5. There is no state line, so not to confuse you. But you can see there's a pretty sharp dip from the beginning of the year where things were really kind of rough. And you can see things have decreased and sort of leveled out at a little bit more of a tolerable level, I would say. So I've bombarded you with a whole slew of data. I think, you know, obviously in leadership roles as you are, you're used to absorbing lots of data, so rapid fire. But what does this all mean, right? So what should we do with this information? And, you know, what is reasonable? And I think that is what the Collaborative of Hospital Emergency Services, or CHES group, is trying to do, is say, you know, what do we expect of EMS? What does EMS expect of itself? What do the hospitals expect of themselves? What do we expect of ourselves in the ED? We proposed a couple of different options from the EMS perspective. I don't mean to be a naysayer, but ET3 and alternative destinations, while we continue to pursue them, have generally not experienced great uptake. There's actually a jurisdiction on the Eastern Shore that was doing this without even being able to be reimbursed by a healthcare insurer. And some of the challenges with this alternative destination approach is, unfortunately, patient-centric. Patients call 911, they think that they're having an emergency. We've said, you know, prudent layperson standard and so forth. Or if not, the patient will make the call to an urgent care center, an alternative destination. They say, yeah, I don't know, you know, that seems a little bit much. Like, what if I have to get a CT? I'm not really sure about that guy. Maybe you better just take him to the hospital. So our risk threshold, again, not to put anybody under the bus in particular, but our risk threshold, as all of us know, outside of the ED is not necessarily there where many of our partners are willing or able to see undifferentiated patients. So we do have a challenge there, something that the royal we in the healthcare community can improve upon. I'll leave it to you guys to decide whether direct to triage protocols have been successful or not. I generally tend to practice relatively conservatively, I think. And I think that the direct to triage protocols are relatively conservative. I think they're very conservative in how they're written, but my experience has been that things tend to be implemented, a standard deviation or two off from where they're written, if I could put that nicely. But direct to triage protocols, in essence, our goal with that was just because we bring a patient into you by EMS doesn't mean that that person should take a place in front of the line as opposed to the sicker patient who's been there for hours waiting in the waiting room. We think that would really it certainly would send the wrong message. And it would also indicate that somehow the mode of conveyance to the hospital was more important than the actual patient's history and physical exam and so forth. So just because you come by EMS, we do know that EMS patients are admitted at a higher rate, but just because you come by EMS doesn't mean you should take your spot at the front of the line ahead of somebody that's been in the waiting room for several minutes or hours. We have had some success stories. We've had some challenges, to be honest with you, with both of these attempts at really trying to improve the efficiency of the process. But our next steps really involve trying to say, let's level set. We have some regional alert policies in Maryland that are very old. They date to the 1990s. They were last updated in around 2001, 2005. And it's really time, whether we have a challenge or not, to reevaluate those and level set and say, what do we expect of ourselves as a system that provides emergency medical care? And I think hopefully you'd agree with most of these statements. I think we'd all want, if we were patients or our family were patients, we'd all want a safe and efficient EMS to ED transfer care process. We'd all really expect EMS to provide stabilizing care and convey the patient to the ED for continued care or definitive care. We'd all expect the ED to receive patients that are cared for by EMS, and there are some hospitals that EMS delivered patients constitute 40 to 50%, believe it or not, of the hospital's census. I know that's not the experience in every ED. Some EDs, EMS patients account for a much lower percentage, but there are some in our state, some in the city of Baltimore, actually, where the EMS delivered patients account for 40% of the ED census. And I think we'd all agree that every after action says that the weakest point is communication, that any process or process improvement, provided that everyone's committed to it, requires effective communication and collaboration. Where I think the rubber meets the road for a lot of us is that we incur responsibility for the patient when the individual arrives, even 250 yards before. But until a physical transfer has occurred, EMS should continue to monitor the patient's condition, continue their ongoing therapies, and report changes in the patient's status to ED staff. One thing that's key, though, is that they're not credentialed to practice in the hospital, and they really should not be initiating interventions once they've reached the hospital without a physician order. Without breaking confidentiality, I'll tell you that some of the worst QA cases that we have in the EMS world occur within the hospital's walls. We've had medication errors, and this is really, gets down the line with EMS trying to do a level of care, continued level of care that they're really just not set up to do. So they'll make medication errors, they'll a variety of different things to try to make the patient comfortable or try to treat the patient's pain. And we've ended up with at least 2 or 3 very high acuity errors that I'm aware of. And then I think this is something that the collaborative group, ED leadership, hospital leadership has been working towards is, what do we expect of ourselves? An efficient transfer of care process. I think in most terms, in most forums, we've heard people talk about different time ranges, but in general, within 30 minutes of the EMS patient arriving, taking into account that it takes 5 to 10 minutes to get in the door, triage the person, et cetera, and that 5 to 10 minutes should not be within that 30 minutes, that should be in addition to. to 30 minutes, so more like 35 or 40. But this takes shared problem solving in real time. We can talk about 90th percentile, but we know when we get multiple sick patients at the same time that we're going to have challenges. So not committing ourselves to 30 minutes all the time, but most of the time, 90% of the time. So what I would propose to you, or sort of my ask of you as leaders in emergency medicine, is that we should want a safe and effective EMS to ED transfer process. We really should want, for patients who are not meeting direct to triage protocol, a face-to-face handoff in the ED going to a treatment space. We should want this within about 30 or 40 minutes, 90% of the time. So that would be my ask of you, at least to consider going back. So what does this look like? I saw I have a question here in the chat, and please ask me questions. I apologize. Is there a wallop biopsy before diverting to urgent care centers? That's a great question. I'm going to pause for just a moment as we ponder that. So those programs that were involved in a government demonstration pilot, a CMS demonstration pilot, we asked those receiving destinations to receive all patients regardless of their ability to pay. That was stood up in Baltimore City, Montgomery County, and the city of Annapolis. Montgomery County has actually gone offline with that pilot because there was really such little uptake from both the patients, urgent care centers, and the EMS clinicians. And in those specific cases, Dr. Bond, we had asked those receiving destinations to agree to see the patient regardless of insurance status. They certainly could bill the patient. But that is another key barrier, and thank you for highlighting that outside of that ET3 demonstration project, there are no EMTALA obligations by urgent care centers. And so while we have de-emphasized that, we essentially have said we're not in favor of EMS clinicians asking a person their insurance status. There are several urgent care centers that say, well, before we're going to accept your patient, we need to know. So it is a barrier, frankly. That's a great question. So I just want to circle back to a sort of a general tenet. What we're trying with both EMS and hospitals to achieve is to have each side sort of lay out the expectations of themselves, as opposed to what's easier to do, which is to lay out the expectations for the other side. It's very easy for me to, lay out what I may expect of Dr. Gatz. It's much harder for me to lay out what I expect of myself. So what EMS ought to expect of themselves is that they enter the ED with the patient, that there's an organized conveyance of information to ED staff, that if the patient is truly not sick and low acuity, that they at least evaluate the patient's need for a bed with the direct to triage protocol and communicate that to the nurse, to monitor the patient's condition, continuing ongoing treatments, but not to initiate new treatments without really getting the physician involved at the receiving facility. Because at that point, the patient is at the receiving facility, and unfair as it may be, we're on the hook for treating the patient at that point. And then to assess the system, the overall EMS system's ability to accommodate an ED bed delay, in the sense that if we've got 2 cardiac arrests at 2 in the morning when there are low call volumes, they may be able to accommodate a lot more delay without a whole lot of hurt to the overall EMS system. If this is, however, on the other hand, 11:30 a.m. on a Monday, when we know things are off the hook and Baltimore City or a given jurisdiction has got 6 or 7 calls waiting in the queue, for 911 calls, the system's ability to accommodate additional delays is certainly impaired at that point. My slide stopped advancing there. Oh, there we go. So likewise, expectations of the ED, what we should expect of ourselves in the ED is that we are going to receive patients. We may want to facilitate direct to triage, because at the end of the day, direct to triage is essentially triage. It's a fancy name for triage and triaging the low acuity to the low acuity area. We should ensure that the patient's registered in a timely way, really not so much us, but the nursing staff. We should want to assess the patient to prioritize the queue and assign an appropriate space for them, and identify appropriate spaces for patients, which may not always be beds. And then really assess alternative options if a space is not immediately available. in the main treatment side of the ED. So from working out from 0 to 30 minutes, we said again, 30 minutes, around 30 to 40 minutes, we'd like to see, 90% of the time, us being able to accommodate the incoming EMS patient. But what do we do at 31 to 60 minutes? Things are locked up. What we expect of EMS is at least to advise the ED staff of the ability to accommodate additional bed delays, to record that bed delay, again, to inform the decision with data, to discuss with their supervisor their delay, and also to, again, assess the system ability to further accommodate bed delays. Notice I put that at the beginning and the end, because a lot of this depends on the system's ability to absorb additional delays, either at the beginning of that 30 minutes or the end of the 60 minutes. And similarly to the ED staff, what this slide is basically laying out is what many term an escalation policy, to make sure that the ED charge nurse and the lead physician are aware that there's an EMS patient that's waiting due to ED bed delay, that the tracking system denotes that the EMS patient is waiting, that there is additional appropriate clinical space that we may need to use for the patient. And one of the things that I took away from St. Joe's is that just having that ED patient on the board, or that next patient on the board, in a sub-waiting room status as a person to be seen, and I think we've gotten a lot better about this over the past couple of years, really means a lot. I mean, that's a patient that is now ready to be seen by the doctor, labs ordered and so forth. It may not happen right away because we're short-staffed, but I think prior to 2 or 3 years ago, a lot of patients went to the waiting room, and even though we were accountable for those patients, they were generally out of sight, out of mind. I think that whole paradigm has shifted over the past 2 to 3 years, where we have really, we as EM physicians have stepped up to the plate and seen those patients more actively. And again, at over 60 minutes, we really need to try to identify a clinical space, moving the patient from EMS to ED equipment. At over 60 minutes, this is really where I think a lot of the leadership becomes involved, is that the ED nurse manager, the ED medical director, and on-call administrator really need to know about this to be able to try to the extent possible, pave the way to make an accommodation. I think logging notifications and acknowledgements goes a long way to demonstrating, both for administration at the ED level as well as the hospital level, the number of times we had to, get Dr. Gatz involved to be able to clear a bed or clear a clinical space to accommodate a priority 1 or a priority 2 patient, or a high priority patient that could not go to the waiting room. And again, I think identifying space is something that we've done particularly well. I certainly know that we would love to solve the boarding crisis tomorrow. I certainly know that that is a problem that has developed over many years, that many of you are far more knowledgeable than I am about. But what I would propose to you is that we continue to have these discussions with administration at the hospital level, and really not mince words and frame this as a patient safety issue, which I think it is. Again, we have people who we've trained in initial stabilizing care, continuing care. The 911 calls don't stop when we enter the ED, and we need to really make sure that we're conveying this for what it is, a patient safety issue. I would certainly value any discussion or feedback or Q&A, but I wanted to just sort of plant these thoughts that as we move forward, it's going to be important that we engage ED leadership to promote an active and efficient EMS to ED transfer of care process, that we collaborate with EMS leadership. And I know that personalities can sometimes get in the way. Certainly, not everyone necessarily wants to be as collaborative as we would like. And that's part of the challenge, is as we face with patients who don't always want to collaborate, is that we need to try to collaborate with people who have a different point of view. But please know that above all else, although the EMS leadership may come across blunt, that really what they value the most is being able to answer that next incoming 911 call that unfortunately no one else is going to be able to answer besides them. And that I think as we go through this, that we try to come to some agreement on goals and then agree to measure our progress towards a reasonable goal. And this is something that Ted Delbridge and I have discussions with EMS leadership all the time. There are several leaders who may want to snap our fingers and say this is, intolerable. We need to fix this tomorrow. We remind everyone that it took us a long time to get to where we are. It's probably going to take us a long time to get back. Just like a patient who has had pain for 2 years, pain started over 2 years. We're unlikely to be able to fix that pain in the next 20-minute ED visit or however long the ED visit may be. But what is most important is that we get it on the right track and that we have meaningful progress towards a reasonable goal. I think all too often prior to this recent discussion, we were in the progress of sort of saying, we're working on it, we're working on it, we're working on it. And EMS was sort of in the same boat, we're working on it, but we weren't really defining any goals to our, for ourselves to try to strive for. So that's the end of my canned slides. But again, I'm very grateful for your time. I didn't want to go over time. And I'm certainly happy for any discussion or feedback that you guys may have. And Steve, I saw your message there. If you had to depart, no worries. I appreciate it.
Tim, I got a question for you.
Yes, sir.
What is MIMS doing to try to potentially load balance EDs? I'll give you an example. Gats and I were working together the other night. I do mostly nights, but occasionally get thrown on a day shift or an evening shift, and it throws everybody off. But we made the mistake of registering our first DOE, which was a cardiac arrest, as a BOGO. That was the first name we gave her, is BOGO. And then the rest of the night, we bought one, got one. So a second cardiac arrest immediately followed the first. And then we had back-to-back Baltimore County strokes coming in, both of which were not strokes, by the way. But that's really hard to offload that many, critical one patients. Is MIMS trying to come up with a system where they could load balance and know what's incoming into the hospitals so that EMS knows, hey, we just smacked university with 4 priority ones. Priority 2s, priority 3s are going to be waiting a while because we just overloaded them. Maybe it might be a 2-minute longer transport time, but overall the patient will get better care because we're load balancing. Is there anything in the works for that?
Yeah, no, thank you, Mike. That's a great question. Thanks for asking that question. So a couple of things. In the major metro areas where most of you are, so Baltimore City, now Baltimore County, as well as Prince George's and Montgomery, now during peak hours, these counties have fielded what's called a medical duty officer, whose job is just that, is to try to find the most appropriate place to load balance the system. I know Dr. Launer did some research on this and sort of found limited effect, but we don't, I don't think we're certainly not abandoning that effort, that a human might be able to realize, hey, a patient is not a patient is not a patient. If we sent a cardiac arrest to Midtown and we sent like 3 abdominal pains to Sinai, that the system's ability to absorb 3 abdominal pains is different than 1 cardiac arrest. So there's an investment of human capital in that. And again, that's a position that really didn't exist prior to, about probably 5 or 6 years ago now, really to just try to load balance the system. The other interventions, the other things that we're on the cusp of being able to do.
Can I make a suggestion though? Can it be state level, like in your office, MIMS? Because the county lines are imaginary. So Baltimore County's doing its thing, Baltimore City's doing its thing, Anne Arundel County's doing its thing, but they all wind up in Baltimore City. It really needs to be a state level approach if it's going to be effective.
Yeah, there's been some discussion short of state level between Baltimore City and Baltimore County, particularly, Mike, at making it regionalized. And I think Baltimore County wanted to get their feet under them with doing it at all. And I do see that evolving in that direction, because I agree, this is not, patients do cross county lines with a lot of regularity. Frankly, patients cross regional lines. There's a lot of cross-pollination between Region 3 and Region 5, especially. So I would love to have it go that way. I do know with the volume involved that we would have to divide the workload in some way, shape, or form. Especially if you're dealing with that region 3 statistic that I cited, which is, essentially a call every 2 minutes or transport every 2 minutes. We would have to divide the workload in some way, shape, or form. So I don't think we would ever get to one person that's statewide. We would still have to divide that workload up somehow. But your point is well taken. The other thing that we're really trying to do to inform those MDOs as well as inform the ground is to add to this dashboard that's up on the screen now, the at hospital ambulance dashboard. Right now, we show the units that are at the hospital.
You can't see that, Tim.
Yeah, it's not up.
Oh, sorry.
Tim, all we see is your slides, just so you know.
Sorry about that. Let
That's
me
fine.
reshare. Thanks for letting me know that. It's like when you're talking into the abyss and nobody tells you and they just let you keep going. Appreciate that. Can you see it now?
Yeah.
Yep.
Okay. So this has been out for some time. We've been really trying to push this over the red and yellow alert system in order to try to wean people off the red and yellow alert system. We've actually kept the red and yellow alert stuff on here, but it is our goal and desire to remove that over time. This is a sort of an attempt to wean people. So right now we show the unit, the number of units that are available, that are at the hospital, not available at the hospital, and the range of time that they've been there. Our recent capability has been augmented by the fact that we can also put on here the number of units that are going to a given hospital. So moving forward, once we get the technology to cooperate, Anne Arundel Medical Center would say, 1 unit's arrived at the hospital, they've been there 8 minutes. And by the way, there are 3 units that have marked, I'm on the way to Anne Arundel Medical Center.
Oh, that's cool.
So, at least that ability. Now, what we lack is this captures out of the patient care record system, the electronic health record, which is generally not completed on the fly. So we lack the ability to really to capture in an automated way what they're bringing in. Like unit 1 is bringing in chest pain, unit 2 is bringing in abdominal pain. We're not quite there yet as far as the acuity goes. Hopefully one day we can get there. But I think, again, that will help inform the decision along with the emergency department advisory system that is right now in the court of CRISP, awaiting data integration. The thing that's holding that up is we're all a little bit different in how we categorize our borders. Some hospitals in the admission discharge transfer feed, the borders disappear. It looks like they went upstairs when in fact they still remained in our ED. Obviously, we know that it's very important to count the borders that are occupying ED bed spaces. And what that'll do is inform a score of 1 through 4 based on the ED census. So they'll have a score, it'll say Anne Arundel is super busy hopping. It's a 4. There's, 3 units there already, and there's 3 units on the way. But some of our so with all these decision tools, all these decision tools are great. The challenge that we've got that is kind of longer standing in Maryland is that in the densely populated parts of the state, we do hit points where every single hospital we've hit a saturation point where every hospital is in the same boat. There's 4 units at every hospital. There's a cardiac arrest that went to every hospital within the past, 2 hours or so. And that is the larger policy challenge that we've got, I think, as ACEP and ED leadership, is to say there's very little wiggle room left. It used to be, back in the days of Church Home Hospital and Baltimore City Hospital and so forth, there used to be some wiggle room where, like, if Hopkins was super busy, maybe Church Home could take the patient, or, Bon Secours could take the patient. We've got, I think I'm preaching to the choir here, we've got very little surge capacity anywhere in our system. So I guess, Mike, it gets to that point, Mike, and for everybody, it gets to the point where what do you do with EMS when everybody is getting belted with critically ill people?
No, I agree. Nobody's expecting perfection. I'm just thinking of system approaches where we might be able to fix it 80% of the time, 70% of the time, or at least to let EMS make better decisions so that the patients are better taken care of.
Yeah, I mean, I think
they always get, the EMS guys always get killed anyway. Like they'll bring us a patient that gets all their care at Hopkins, and they always get attitude for that. It's not their fault. We shouldn't be giving them attitude, but we're like, that we were the closest hospital. They were sick. We should take them. But people always give them attitude, and I just hope they don't take it personally.
Yeah, no, I appreciate that. And the other thing is, and this is a little bit of a touchy subject as well, but I know several of you are in the city, practice in the city. There are fairly wide ranges, but they're consistent week over week as far as what the total EMS volume is. Like you might be surprised, or you might not be surprised, that the EMS volume can be as low as 50 or 60 going to a given facility, and it can be as high as 380 or 400 patients at a given facility in geographic Baltimore City. There's that much variability, but the variability is consistent. It's so the challenge, I think, is we have, and again, without naming specific places or specific hospitals, we have some hospitals that have grown accustomed to what they typically receive in terms of EMS volume, and it is a big jolt. I mean, there are some hospitals in Baltimore City that are used to 350, 360, 370 EMS patients a week. And there are some hospitals that I can tell from the weekly reports if they usually get 200 and they get 220, the times are through the roof. I mean, they're again, getting back to the actual capacity and the wiggle room in the system. But again, if you just purely went on a numbers game, you have some facilities in the city that are getting, roughly 10 EMS patients a day. And you've got some that are getting, up to 30 EMS patients a day. It would be interesting to see, if you just completely level loaded the whole city, how that would go.
And we know that can't be done exactly, because like University and Hopkins get killed because of being comprehensive stroke centers, right? Like we had a LAMP score of 0, no focal deficits, but they brought it just because the patient was confused.
Well, I think Franklin is now a comprehensive stroke center.
Yeah, so those centers, I think, get overly abused because they don't want to miss that call.
I'll tell you, it's interesting not to, I'll be careful, but I'll tell you the busiest city hospitals are actually on the edge of the city. Maybe that would surprise you. The busiest EMS receiving hospitals are on the edge of the city: St. Agnes, Sinai, and Bayview. Bayview is actually the hospital that I mentioned that has the highest proportion of EMS delivered patients as part of their ED census. That's the one that's it's about 40% of the volume that goes into Bayview is delivered by EMS. So to your point about the county and the city cooperating, that not all of that is county. Even the city tends to take preferentially to those hospitals that are on the edges. Because I think a lot of it is some of the behavior you said, Mike, is that they in some sense know that they need to preserve University and Hopkins for some of these highly complex transplant patients or other patients that are just or the highly complex pediatric patients. So I think that they think that goes into their thinking, but maybe I'm overthinking it. How's that? I talked myself completely in a circle there.
Jim, I would just wonder, if you have people in your hallway and the same jurisdictions bringing you 5 ambos in an hour, is there a way not to do that? I mean, 5 ambos from the same jurisdiction, when you're getting ambos from 3 jurisdictions, they've got to talk to each other.
Yeah, unfortunately, and Bob, where you're located, the busiest ED in the state, as well as the busiest EMS receiving ED, is Anne Arundel Medical Center, and the 2 Anne Arundel County hospitals and the hospitals in Prince George's County. I think, again, I know this is not a popular stance or a popular point of view, but I believe that if you were to build another hospital between Anne Arundel and Prince George's and Howard County, you'd probably fill it up in a heartbeat. And I can watch this sort of like time-lapse photography as the day goes on. that core part of the state where there is, and I know it's not popular to say, there's a raw lack of capacity. There is nowhere to go. It is not uncommon for Anne Arundel and Baltimore, Washington, and units that are, and hospitals that are just around you, just to the south of you, for this dashboard to say 8 units. I mean, and it's not uncommon to see that.
Terrifying.
So, I know we're here to talk about EMS transfer of care and making an efficient process, but I hope that I'm at least planting the seed with you that we are under capacity. I know that it's not popular to build EDs, it's not popular to build hospitals. But until there is a high-tech outpatient place where you can go and get your CAT scan and your ultrasound, and your primary doctor can refer you there all hours of the day, so to answer your question, Bob, in your particular case, you're seeing some of the overflow from Anne Arundel County
And St. Agnes.
and St. Agnes, and you guys are at a real crossroads. So it is challenging, again, with adding the units that are going en route to that hospital. That will be statewide visibility. So the Baltimore City guys will be able to see that there are 2 ambulances coming to your hospital. It won't really tell them which jurisdiction they're coming from, but it really doesn't matter. What matters is that there are 2 ambulances coming to the hospital, whether they're Baltimore City or Anne Arundel County or Howard County, for that matter.
There was a time, Tim, where I remember you bringing up that we were talking about some of the patients being cohorted with one EMS provider when there was just overflow and, transferring of care was taking so long. And I haven't really seen that in action. Is that actually something that's occurring now?
I think during COVID, there was a lot of discussion about that, Idana, but the feedback that essentially we got was, in addition to that the staffing wouldn't even allow for it. And we've seen that similar to nursing, and I don't know that we as physicians have seen it as much, but at least akin to nursing, where they've had, essentially 10-20% of the staff on the EMS side, quit, move on to other jobs, things like that. So I think the staffing just, would not allow that to happen at all, and so then the discussion becomes, if they can't get to the 911 calls, and that's a crew that otherwise could take, the next 911 call. That's really why the idea gained no traction.
But it makes sense, though, if you send two crews off, right? And when one crew keeps 3 patients, it just kind of, it seems like more would be in business.
Yeah, I think it's, I think their fear was more along the lines of what we ended up with ED boarding, where I'll say we were unwilling participants, right? I mean, we didn't, but I can remember times, 10 or so years ago where, we would get excited about having 3 boarders in the ED, and we just sort of grew into that, right? It was just like, oh, well, there's one more boarder. Oh, there's one more boarder,
right?
So.
I can see that.
It's not lost on me, though. Like you said, I think that was their reluctance to do that. So,
I had another question. So I often have patients say, or EMS providers say that they were asked by the patient to come here. And, they're always stable, and I think that's fine. But would that be something else that would be taken into account by the, depending on the status? I know when, we're on red, they don't come, but very commonly when they request to come to a certain place, they certainly don't go to the closest hospital. And I wonder how that's going to play here when.
Yeah, so some of the other states, Pennsylvania actually incorporates that into the decision-making. We have not formally put it in the MIMS protocol. And what we have put in the MIMS protocol, though, is what we call repatriation, which is if you've been admitted to a given facility within the past 30 days, and it's reasonable to get you back to the initial facilities to get you back there. That's another real function of the MDO that we're really trying to work on them to say, as you're load leveling, like, don't take somebody that just had their belly split open at university to Hopkins. It doesn't make a lot of sense.
Yeah.
Because it's just going to result in a transfer and a delay, and
that makes sense. Yeah.
There's a fair amount of nuance to this, right? I mean, it's Because that, I mean, that makes no sense. No surgeon's gonna
No,
have
but
somebody that was just operated on another place.
No one will be happy.
I just want to, that's where I want to go, and they're very far away, and it just doesn't always make sense, but.
Yeah, no, there's definitely a lot of nuance to it more than ever. Certainly the thing that helps us is at least we can see, in contrast to 10 years ago, we can see, oh, patient was just over at Mercy, well, they got this workup. I mean, I can remember like, where we were manually making phone calls, hey, what'd you do with this guy? At least through CRISP, we can see, oh yeah, they went to Franklin Square and they got this and
So
this and
that
that.
before patients are transferred anywhere, there's a CRISP review?
No, I was just saying us and ED, that we at least can see for some of the medical patients, taking the surgical patients out of it. But still, unfortunately, we'll get some patients that say, and I'm not sure what why they do this, but they didn't like us at hospital A, so we want to go to hospital B. I mean, if hospital B is on the other end of the state, clearly they're not going to do that. But if all other things are sort of equal between hospital A and hospital B, there's no formal rule that says that the paramedic has to accommodate the request. They can. Just we'll get some people, frankly, that will say we recommend you go to the closest trauma center. They'll say, well, no, we're not going there. Particularly on the lower end of the trauma decision tree, the category deltas. And they say, well, I'm not going there. I'm not going at all. So then we're faced with the decision of, do we take them somewhere, or do we let them refuse and stay there and try to figure out their own way to the hospital? Just an example, for instance, we'll get some people that'll say, like, if you don't take me, as you may imagine, if you don't take me to Calvert Health, then I'm going nowhere at all. So as we do in the ED, we have to find a way to work with people.
You can't say fine. Do you have capacity?
I mean, we're not going to truck you from Carroll County to Bayview, but we'll try to be reasonable with them.
Yeah. Tim, can I ask, in terms of the transfer of care, and we talked about these time goals, and obviously we have these outliers in particular that we're trying to address. And as I think about RED is looking to dedicate like specific nursing resources to this, do you have these like delayed transfers of care broken down by hour of the day? Because as you kind of alluded to already, right, 2 p.m. is not the same thing as 2 a.m. in terms of total EMS traffic. Is there like a certain window of the day where, like, if an individual AD was like, I'm going to throw extra money from, I don't know, 3 p.m. to 10 p.m. because that's where the real issues are. Do you have that kind of nuance to the data?
So as part of the weekly report, there is sort of an individual case listing that has the date and the time that they arrived. I'll tell you, in general, probably no surprise, it tends to be anywhere from 3 as early as noon, but usually around 2 or 3 in the afternoon until sometime after dinner around 8 or 9 is where we really start to see these start to bottle up. I mean, in Region 5, the longest time that I'm actually aware of was 8 hours, where the patient was on the EMS stretcher. But it tends to be within that general zone, Dave. I mean, you're not really seeing it in the middle of the night, as you might expect. You're not seeing it in the early morning. You're seeing it in the afternoon and into the early evening.
Gotcha. Okay. So kind of that, like, maybe as early as noon, but noon to 7 p.m. window.
That's where it tends to lie most of the time when you look at these really high numbers.
Okay.
And frankly, as far as practices go, oh, sorry, Dave.
No, please go ahead.
No, as far as practices go, I know that there are some hospitals that have actually, made this sort of process front and center for their ED charge nurse group, that, they know by the charge nurse, whether or not they're dispositioning people, much like our door to doc times. So I know that's been, charge nurses may not like it, but that actually has been done in a couple of hospitals with some reasonable degree of success.
Yeah. No, I mean, and obviously as you kind of pointed out, you know, we're all on the same side here. And so many of your slides, right? You could just simply replace EMS with ED and ED with inpatient hospital. And the same story is completely true, right? It's the same issue, the boarding backed up to the ED and out of EMS. We're all kind of fighting the same battle. And as you noted, it's intolerable, but we can't snap our fingers and create a solution. The goal is hopefully as we make some movements, and I know UMS is got a lot of ideas on the table. Getting them adopted is another story. But if we can actually get some surge capacity plans adopted and implemented, it could make significant changes for our ability to really accommodate EMS.
Yeah, and there's Dave, you hit the nail on the head. I mean, MedStar, Hopkins, we've got all of them represented on the line here. In each system, there are some of the best performers on this particular topic, and there are some of the worst performers.
Yeah.
Believe it or not, within the same system, it's amazing. I'm aware of one system where I think they have close to the best, if not the best, transfer of care processes, and they have another hospital that's close to the worst. You know, where that 90th percentile time has been as high as 130 or 140 minutes. You know, and that's 90%. That's not accounting for the 10% above that. And the same hospital system has one ED that the median is like 10 minutes and the 90th percentile is, 24 minutes. So same system. So, comparing notes within the hospital system is also a good place to start. And I know UMS has started to do that.
Yeah. I mean, I truly believe it's a little bit of apples and oranges. I mean, every hospital is going to be so unique in terms of their own needs, their own populations, their own degree of boarding, their own, like, where do our patients come from? I'm sure Hopkins is very similar to us, where like my number one chief complaint is provider referral, right? They were in a clinic earlier in the day. They're like, oh, your transplant's not working. Go down to the ED to board for, 2 days for your admission. And it's tough. It's real tough to work around. But obviously we have to make changes because, I know that university's total EMS volume is not particularly high. And that makes me very sad because we're a teaching hospital. We have residents that want to learn, need to learn, and a lot of the best cases, they don't walk in through the front door, right? I mean, they come on an EMS stretcher in the back of an ambulance zipping down the highway. So there's a lot of motivation and desire to make it, possible for this. I'm curious for your thoughts. Let's say, like we have, I think we're going live, I think April 20th with our new EMS RN role for downtown. I think one of the fears though is I implement a process to try and improve like our local institution, but everyone in the system is slowly making their improvements at different times. I don't know if Hopkins has already made theirs or Harbor's made theirs, maybe they're a month down the road. Am I just going to end up getting punished essentially? Like I make a little intervention, I get a little bit better offloading. Everyone's like, oh, great. Let's go to university now. And now I'm like, and it just feels like I'm doing even worse all of a sudden.
That's a great point. At one of the earliest collaboration meetings that we had just prior to COVID, that very point was raised, and essentially it went something like this. When one hospital stood up and said, well, I got to have yellow alert because when I'm low staffed, I got to go on yellow alert, to let everybody know. And it was not an EMS person; it was actually another hospital person that stood up and said, well, wait a minute. It's your job to staff the ED. Like, why am I picking up your slack? Hospital talking to other hospital. So I think there's a lot to be said about, frankly, peer pressure. And this is where networks like ACEP, and other sort of venues become useful in the sense that, if Idana is doing something at Hopkins and Dave's doing something at Hopkins and Bob's doing something, Dave's doing something at university. But LifeBridge is not on board, just for instance, I think it's incumbent upon us as a practice management group to say, we're doing all this stuff. Why are you guys not doing this? Sort of, again, getting back to what are our reasonable expectations of ourselves as a specialty. To your point, David, I think we want to bring everybody up. We don't just want piecemeal interventions at hospital A and then everybody else gets crushed, or vice versa.
I'm sure it's also watched very closely, right? So if that's happening at one hospital, it will be communicated that this is going on, and we want to do the right thing for the patients, right? That really is our goal. So
yeah, and we've MIMS has not gone public with the data that the hospitals get weekly, but I think if the hospitals jointly said, look, we're investing all this time and effort to do an efficient process, and there's a couple slackers out there and we're proud of the progress we've made, and we want the stuff to be public, then I think we might consider making it public. But we would want the hospitals to really know it's not, it would be in the spirit of trying to improve. And the opposite thing goes as well, Dave, is regression to the mean. Like if you're a hospital and you're doing kind of okay, but you see like everybody else is sort of like 10 minutes behind you, just like when you give TPA, you're like, yeah, I got a little more time in the window. I can just sort of let this ride a little bit more. So the peer pressure works both ways.
Yeah.
If Bob's doing something really good, but Dave's being a slouch, he's got a little bit more room to be a slouch along with you.
Yeah.
I'm just kidding. I've known you guys for a while. I know I can speak openly with you. And this is something that I know, again, our first inclination is to try to help the patient, be patient-centric. I know that this is not an ED problem, that this is a larger hospital problem. What I'm hopeful for is that, as you said, Dave, we're fighting the same fight, that we can be advocating for, we're not just backed up into the ED anymore, we're backed up onto the street, which is kind of where we are.
Yeah. Because I can so easily see, it's just like patient experience scores, right? You get something that's posted publicly, hey, these are the EMS offload times for the entire state. And what happens, the C-suite starts flogging the emergency department with a vague plan of do better. And that's where it's just, I think it's unified. And I think Bond was alluding to this earlier, right? I think it's fine to publish that information, with the message, right? Like it's gotta come from the hospital. It's not an ED, right? This is just the presentation, the symptoms, as we all know. I do want to be respectful of everyone's time. I also want to, I'm sure there are going to be a number of people that have a chance to kind of watch this on probably 2x speed later on, and get in some additional EMS questions. One situation that I've seen come up a couple of times, that's not directly related to this, but I was wondering if you could comment on is, as you know, boarding becomes our problem, and part of that is sometimes a transfer, right? I have someone downtown that I want to admit to Midtown, and they wait 8 hours for transport, and occasionally I'm seeing EMS units being used to facilitate transfer. I'm thinking of a situation just last week within the system where it was, I think, out on the shore, maybe. I don't know. Someone had a significant injury. They needed to be transferred downtown for a medical procedure with one of the medical specialties, and they were waiting forever. There were some complications because they also needed bariatric transport. It wasn't happening, and eventually an EMS unit stepped in and actually facilitated that transfer, which was huge, but also not their job. I don't know. It's really helpful. And it ultimately, I'm sure, helped the system of care throughout EDs in the state. So I'm just curious about trends and rules with regards to that.
Yeah, so great question. The answer is they may do those transports. They're not required to do them, but they can on a discretionary basis do those. And in different parts of the state, the hospitals sort of begin to rely on those for high acuity people, just to be able to move, get people to higher levels of care. There is a study that was presented to the legislature on the adequacy of interfacility transport just this past year. So we've been calling for.
Surely it was the inadequacy, right? I mean,
yeah. So spoiler alert. There are a lot more resources that are needed to shore up. We talk a lot about 911, but the interfacility transport process as well. And especially as we tend to regionalize care, and which can be a good thing. We haven't always followed with what some other states will do is to invest more heavily in the transport of patients between hospitals with directly owned hospital ambulance services. And I know that is a whole nother discussion. It can be a lightning rod. But the commercial vendors out there, and I'd be happy to kind of discuss this, more in depth with you. But it's a whole nother conversation. The commercial vendors sort of operate in a contractual basis. So if they have a contract with, hospital A, they're going to go to hospital A first.
yeah.
We tried very briefly creating a marketplace like Ride Central, I think. But it's not necessarily a competitive atmosphere. It's so contractually based. So the answer, short answer is the 911 services can do, discretionary transports interfacility wise, but I would really try to keep it to high acuity, like somebody needs to go directly to an operating room or a cath lab table.
Gotcha.
There's lots of BLS transports that are really done just because the patient doesn't have a vehicle. And there's this misconception that just because they have a peripheral IV, they can't go by like Uber or Lyft. If that messaging could get out there, that could save a lot of ambulances right there. Like, unless you have fluids running or need oxygen, like there's alternative transportation methods that would be a lot quicker. Uber will be there in 4 minutes. I don't know any ambulance that gets there in 4 minutes.
And we send a lot of people out by Lyft, and the Hopkins, will pay for it. I don't know how that would work with patients going by. I mean, the state, how would we charge? How would they charge? I don't know how they pay for that.
Yeah, I mean, slightly above Uber and Lyft, although viable options. If the patient doesn't really require an attendant or ongoing medical care, Dr. Bond's point is well taken. There are also services that we globally call wheelchair vans. So wheelchair van doesn't necessarily have to be in a wheelchair, but is essentially a high capacity van that you sit in the back of, and then there's a driver up front. They're not actually even regulated by MIMS. What'd you say?
They don't have headlights. They never work after dark.
After dark, yeah. So I think
I've never seen a wheelchair van with a headlight.
Yeah, I think as long as you're not expecting medical care to actually occur en route, and you believe the patient's stable, the only challenge I guess I would say with that, Mike, is that a lot of people are being transferred specifically for quote unquote higher level of care, which implies that there's some degree of instability. But for somebody that is, like you said, that requires no medical care, why not use them, right? Why not use that resource?
Some of that stuff, it's like for ophthalmology or for a hand, or
Sure,
it's higher level of care, but it's really like, because you have no level of care at your facility. And they really like, if they had a private vehicle, you'd be like, have your husband drive you, because you get there a lot quicker.
Well, they do, right? That most ophtho transfers come by car. It just makes sense that other, ENT, those kind of transfers can also go by car.
Yeah, I mean, and you as the sending doc can make that determination. I know I've transferred probably the greatest proportion that I've transferred from Upper Chesapeake were kids, that needed to either go to Hopkins or Maryland because they needed some diagnostic service. And the parents like, well, I'm not going to wait for an ambulance for 8 hours. I'll just drive them down there. And, as long as the sending and receiving doc are on the same page with that, the kid's not decompensating. I don't personally see a problem with that.
It just doesn't happen, right? I think that this would have to be introduced, because other than ophthalmology, everybody goes by ambulance. In my experience, I don't know about everybody else, but
everybody's afraid of the liability. So I don't know if we could just message that out better, but everybody is afraid that if they don't go by AMBO, my liability goes sky high. And I don't know if there's any truth to that. I don't know if it's actually true though either, but I don't think there's truth to it. And it'd be nice if we could message it out and know for sure. To me, getting them into the hands of the consultant sooner decreases my liability.
Yeah, it's an interesting question. I mean, it's like one of those that I wish, I don't know if Larry Weiss is still around, but I'm sure he probably would have a lot more eloquent things to say about it than I do, Mike.
He's probably not authorized to talk about that.
But yeah,
That
thinking
was his
outside
famous line.
not authorized to talk about it. Yep. And we, Dr. Launer and I, Ben and I have even, kind of approached Medicaid with some of the low acuity transports into the hospital. Essentially, the patient's dead set, they have to go to the hospital. They probably don't need to go by an ambulance going into the hospital. Is getting, Medicaid around the idea you can pay $19.99 for an Uber, or you can pay $100 for an ambulance. Which would you rather do? So, I know that doesn't help us out in the ED, but as far as preserving 911 ambulances for the higher acuity calls.
Or just the transfer ambulances, right? Just the ones that are helping to real transfers.
Yeah. Well, I mean, the challenge with that is that they're actually in shorter supply. Their workforce took a hit a lot sooner than the 911 side. I wanted to ask you guys a question though, particularly those that are around West Baltimore. Do you send many patients to the sobering center secondarily after to the Turk House after you see them in the ED, or no?
Turk House a lot, yeah.
Turk House for sure. Mission.
But not the sober to like as a rehab thing. We don't use it really as a sobering center.
A sobering center. Yeah, I was just curious if you were sending those out by Uber or Lyft or what have you as well.
Not by Lyft.
By Lyft, yeah.
Depends on how sober they are. The Lyfts get mad when they pee in them.
You gotta waterproof them, right? Well, Mike, you'll have to make sure that we bring that up the next time the ambulance inspection checklist comes out, because I always take a hit every year when they want to know why we have to have urinals on the ambulances. Unless you want urine all over the back of your ambulance, just keep the 50-cent urinal on there. Do you feel like you get a fair number in? So what I hear from Baltimore City is that they're called to take patients from the sobering center that we've taken there by ambulance or have made their way there, and the sobering center or Turk House says they're too unstable, they need to go to an ED. Is that your experience, like particularly at University or Harbor? No.
I haven't seen any at University personally.
Okay, that's good. That's good. And I know, Idana, there's always the hope that the city will open another resource on the east side as well for a similar resource.
Terrific.
Gotcha. Awesome. Well, Tim, thank you so much.
Yeah, this is great.
Thank you.
Great info. Thank you for fielding so many questions on a variety of topics related to EMS. But again, on behalf of Maryland ACEP and the Practice Management Committee, thanks so much.
Thank you. I appreciate it.
Thank you.
See y'all soon.
Yeah.
Have a great night.
Thanks.